Yes, I always like to listen to Paul Marek, but I strongly disagree with him. But we'll keep it for the question time. I like to measure the CVP. Oh, yes, I do. And I like to measure the arterial pressure and the heart rate and the urine output and the lactate and the SVO2. I like to measure all these things. I think they are important. Ah, very good. Thank you very much. So, what should I do here? Something like this or like this? How should I proceed? Because we will not stay with the hello for the entire talk, okay? We are in the era of no. Say no to CVP. Say no to the pulmonary artery catheter. Say no to bicarbonate administration. Say no to albumin. Say no to the projector. Say no to... You don't have a wire for me, a cable, no? Ah, very good. But, yeah, you can say no to almost any kind of IV fluid as well. You can throw away almost anything. We do not have so many types of fluids available, actually. But, you know, hydroxyethyl starch, as we have discussed, you can throw them away because they accumulate in the organs of the body. They could even induce pruritus in patients who received it. They may actually result in altered hemostasis, in renal dysfunction. You may argue that more modern HES solutions induce less of these effects with a third generation HES solution. But actually, if you look at the CHEST trial, these patients have a higher creatinine concentration than those treated by saline. There is a greater need for renal replacement therapy. Likewise, in the 6S study, greater need for renal replacement therapy. Throw them away, okay? All right. Now, you could go further and say that in the VISEP study, there was perhaps a greater mortality rate with HES solutions. And clearly, this was the case in the 6S study. We have talked about it repeatedly during this meeting. So, throw these solutions away. You can do any kind of meta-analysis you want to do. The HES solutions will be shown to be harmful. All right, you want to look at another synthetic colloid? Wow, we don't need dextrans. No. They can induce anaphylaxis. They alter blood typing and cross. Throw them away. Gelatins, do you think they have been well studied? They may be just as bad as the HES. You know, it's another artificial colloid. Throw them away, okay? We have enough with the... Well, we could consider some other synthetic colloids, but perhaps you have not even used them in your life because they are no longer available. You consider the pectin from apples in the future, but they have been used in the past, or the polyvinyl alcohols or the polyvinyl pyridolones. Well, you may say perhaps instead of artificial colloids, albumin would be better. Now we have this negative study from Gattinoni and co-workers. It's costly. Throw away the albumin. No more saline? Physiologic saline. 154 milliequivalent per liter of sodium, 154 milliequivalent per liter of chloride in 1 liter. No, that's very bad. It may induce coagulopathy, GI symptoms, renal impairment. We have known it since 1983 that hyperchloremia may induce renal vasoconstriction. We don't want to see that. Haven't you seen the paper suggesting increased mortality rates with saline solutions? This large review of huge databases. This study from Australia with a lower incidence of renal failure when they threw away the saline solutions. Haven't you seen the recent meta-analysis showing the deleterious effects of saline solutions? Throw them away. So what shall we do? Bicarbonate is not very stable in solution. Well, we could use lactate. You know, we could use Ringer's Lactate Solutions. Well, these were developed by Hartmann. You know that Hartmann was a pediatrician, don't you? Hartmann was treating gastroenteritis. So the Hartmann solution is somewhat hypotonic, of course. So that may not be good for your patients. Throw it away. Should we use some other balanced solutions? Should we put some acetate in it, or gluconate, or malate, or citrate? What do you know about the metabolism of these substances? You know something about it? In 1983, we published that acetate included in the dialysis bath could not only decrease the vascular tone, but also the force of contraction. We published it in Kidney International at that time, and the nephrologists actually abandoned acetate in their baths to replace it by bicarbonate. And now it seems to come back in some IV solutions that contain some acetate and some gluconate. We don't know what the gluconate becomes in our body. Throw them away. Some hypertonic fluids? Is there any evidence that they are beneficial? Even in emergency medicine, outside the hospital? No, no benefit. Throw them away. So, I'm reaching the end of my talk. What's left? Oh, yeah! Blood may be the future. No, not really, no. Haven't you seen this study showing that blood transfusions in the resuscitation of septic shock does not improve outcomes? So we are left with no intravenous fluids from now on. We need second thoughts, don't we? Already Jill Yanan mentioned this, and I will go very quickly over that, but in the chest study, comparing HES to saline solutions, there was perhaps a difference in the use of renal replacement therapy, but as you could see, this concerned only 39 patients out of 7,000, but the urine output actually initially was greater with HES than with saline solutions. It's only later, when the patient was urinating quite abundantly, that the HES solutions was associated with a slightly lower urine output. If you look at renal function, the creatinine was a bit higher in the HES group than in the saline group, but the urine output, it was just the opposite. And if you look at the rifle criteria, perhaps indeed there was a greater need for renal replacement therapy with HES, but there was less renal failure with HES than with saline solutions. Less renal failure. And obviously no difference in mortality rate. Now, in these two studies that I mentioned, where there may be an increase in mortality rate for the VISEP study and a statistically significant increase in mortality in the 6S study, yeah, are you sure that these patients needed more fluids? When they had a SCVO2 of more than 70%, a central venous pressure of 12 in the VISEP study and 10 in the 6S study, and a lactate level of 2, only 2 in the 6S study. So that's a big problem for the future of IV fluids if you want to have more randomized control trials. Think at the time it takes to identify the patient, to call the research nurses, to start the protocol. The patient is already resuscitated by the time you have all this done. And then we heard the Crystal trial showing perhaps a benefit with colloids, and in France they are primarily artificial. They don't use much albumin, so it was primarily a study showing some benefit associated with HES solutions and gelatin solutions. And after all, speaking about gelatins, well, they may not be so bad when we look at meta-analysis of the few data we have available today. They are not associated with a higher mortality rate, and perhaps there is a lower risk of renal dysfunction than with HES solutions. Now, colloid solutions are supposed to stay more into the intravascular space. So this may be associated with less fluid requirements in the resuscitation period. Perhaps not a 2-to-1 ratio, because in our studies we never compare crystalloids alone to colloids alone. It's always crystalloids versus a mixture of crystalloids and colloids. But if you review the literature on the fluid requirements in colloid-treated patients and in only crystalloid-treated patients, you can see substantial differences in the amount of fluids required. Look at these data. From the back of the room, you can see that these are clearly not equal. In the chest trial, there was perhaps a greater need for renal replacement therapy with HES, but 33% less fluid requirement. 33% less fluid requirements. So what about the edema formation? Yeah, in the chest trial, the mean fluid balance was less positive with HES than with saline. In the Albios study, the same thing with albumin. So perhaps the cardiac filling pressures would be higher with colloids than with crystalloids? Yeah, that was the case indeed in the SAFE study, comparing albumin to saline. It's the case in the CHEST study, HES versus saline. The CVP is higher with the HES solution. In the Albios study, same thing with albumin administration. Even arterial pressure may be higher in the patients receiving the colloid. And yes, indeed, that was the case, although the differences were not statistically significant in the SAFE study. It was clearly the case in the Albios study with a p-value which was statistically significant. And in the CHEST trial, there were less shock, less cardiovascular failure in the HES-treated patients than in the saline-treated patients. And people don't underline this, because we are in an era where we want to criticize everything. And we like to say, oh, if you give colloids, everything will leak out in the extravascular space. Well, the albumin levels increase when you give some albumin. And this is true consistently in all these studies comparing a group receiving albumin to a group not receiving it. Again, here, that's the Albios data. So, of course, there is some leakage, obviously, but you cannot say that everything leaks out of the vascular space. So if you are concerned about edema formation, not only in the lungs, but in the periphery, in the brain, in the heart, etc., that could make a difference. So perhaps we were too strong with the HES solutions. Perhaps we are too critical with a number of IV solutions, thinking that we have so many others at our disposal. Perhaps we are too critical towards the albumin administration, and indeed, as already indicated by Luciano Gattinoni, albumin has other properties than just the colloid osmotic effect. Albumin does carry a number of substances in our body, and we know that indeed in sepsis there may be an advantage in giving some albumin, especially when the albumin levels are low. It took a while to our Australian friends to really calculate it, but when they did, they found that indeed in septic patients with hypoalbuminemia, albumin administration improves outcomes. And indeed then in the Albios study, you could see, as Luciano indicated, that in the patients with the higher mortality rate, those with septic shock, there was an advantage in the albumin group as compared to the control group. When you target mortality, you always want to avoid these patients having a low mortality rate. Otherwise, your study is likely to be negative. That's what we have seen with the recent studies on SCV monitoring. They are negative, 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 because you target mortality in groups of patients with relatively low mortality rates. And if you like meta-analysis, there is enough on ARDS, on septic patients, and we also mentioned this meta-analysis from the British Medical Journal. Okay, I'll skip the cirrhosis just to emphasize that for the future, you asked me what about the future. We have to admit that there is no perfect type of fluid, as it was written in our series here by our Australasian friends. Well, maybe there are some fluids which are very good, but nevertheless, you wouldn't use them all the time. All IV fluids have their possible side effects. The future, several points to be made in the last 5 minutes. First, IV fluids are like drugs. They may be toxic. But could we afford some side effects? If we admit that with HES there is a higher need for renal replacement therapy, we could also say that there is less edema, less cardiovascular failure. Is it comparable? Is it the same benefit as there is harm? I don't know, but there are pluses and minuses. And this is true for any kind of IV fluid. Don't we have some medications that may increase cardiac output, preserve cardiac function, but sometimes induce renal failure and induce cough? Don't we have some medications that may decrease the myocardial oxygen demand, but may also induce renal failure sometimes, or heart failure? Don't we have some medications that may decrease edema formation, but sometimes induce renal failure? And we all use these drugs every day, don't we? So we weight the pros and the cons. IV fluids are like oral fluids. I think the comparison is very important. You should never take too much of one kind of fluid, regardless of the type of fluid. Of course, we should not drink too much alcohol. But you know, coffee is very bad for you too. Don't drink too much coffee. What about all these drinks with sugar, these Cokes and other lemonades? Oh, no, 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 no. Even milk or water. No, you should not take too much of this. You may develop hyponatremia if you drink too much water. That's called potomania. So regardless of the type of fluids, there are potential problems. And this is to be said very clearly. And that's how, practically speaking, we often mix different types of fluids. The patient already received some saline. Okay, now let's go for Ringer's lactate. Maybe we should add some albumin. Maybe, why don't we give a gelatin? And there is also a time factor. Tonight I will have a beer and probably 2 glasses of wine. But I have not taken any alcohol so far during the day, because I never take alcohol when the sun is up. And our patients may not need the same kind of fluids at the very beginning and later during the course of their disease. So all IV fluids may be toxic. Don't drink different solutions. You may drink different solutions at different times. It's the same for the IV fluids. Do we need further clinical trials? Would you do a clinical trial on coffee versus beer? Is it something that you want to do? Oh, yeah, we need randomized control. I am not so convinced. No, I am not so convinced. Because we have a variety of intravenous fluids, we should be happy about it. Do you think really that in a few years' time we will see that in the New England Journal of Medicine? This is the largest trial to date with 120,000 patients receiving 2 types of fluids, no difference in outcome. Do you want to see that? Really? I know many people today want to see prospective randomized control trials, but they are likely to be negative, precisely because in each of the 2 groups, there may be patients who benefit from that particular type of fluid, and some others who may be harmed by it. It's the same thing as low versus high blood pressure, you know, this totally useless trial that we have seen recently and discussed recently. Do you want to do a study on penicillin in sepsis? Of course it will never work if you take septic patients, penicillin versus no penicillin. Actually, you may find that in the penicillin group, there are some patients who will develop anaphylaxis. And you will say, penicillin is so bad. No, don't give penicillin. We learned from our trial that penicillin can be harmful and that we should throw away this antibiotic. But penicillin can be a wonderful drug if you find the right patient with the gram-positive organism which is sensitive to this particular antibiotic. So one patient is not another patient. We cannot do this randomized control trial on one type of solution versus another and looking at mortality. We can look at a number of other things, and indeed we should have more specific questions. And I think we could find ideal IV solutions reproducing the composition of the plasma. The industry says we cannot put bicarbonate in the infusion. No, that's not true. You and I, we have bicarbonate on our shelves. For the renal replacement therapy, we had Lactate Solutions. We gave them away. Yeah, we threw them away because now we have solutions containing bicarbonate. Back in 1894, there was this Loca solution, including some bicarbonate. So don't tell me it's impossible to put bicarbonate in IV solutions. So in closing, I think we will better individualize the type of solutions we need to have for every single individual. There may be some room for albumin. There may be some room for HES, there may be some room for gelatins, there may be some room for saline solutions or half saline solution, for Ringer's lactate. Actually, it all depends on the kind of patient, and we should individualize our therapies and tailor our therapies to the need of every single individual. So don't look for an ideal IV fluid for all patients in all circumstances. That's foolish. Invite the industry to include some bicarbonate in the solutions, the plasma-like solutions. Consider randomized controlled trials only in selected patient populations, not in critically ill patients. And regard IV fluids like drugs. All can have their side effects, and all can be toxic at high doses. We need to individualize IV fluid therapy as we do individualize our drug therapy. And before we throw away the next IV solution, I think we need to think twice. Thank you very much.